Good morning, everybody. It's a much bigger crowd when you're standing down here compared to sitting up the back. There's actually quite a lot of people here this morning. It's good to see so many people. I'm Ben. I'm one of the surgical registrars working here in Westmead Children's Hospital. And briefly over the next few minutes, I'm going to talk to you about population-based studies similar to the Fontan Registry and how we interpret the findings or the results of these. So when you first look at any of these papers, it can look like a bit of a mess. There's different models, a lot of maths, a lot of numbers, statistics and things that can be pretty confronting and confusing. And if you feel like that, I wouldn't worry too much about it. Pretty much everybody who's been through medical school, and a lot of people who went through medical school and have been practicing for quite a few years still feel a bit like that. So hopefully, seeing as you just had coffee break, we'll run through it, and I'm hoping that there will still be a handful of you still awake at the end of the 15 minutes. But there will be some statistics in this. What is a population-based study? And you'll all have a reasonable idea of what a population-based study is from your involvement with the Fontan Registry. So it's an all-comers registry study. So we don't pre-select out with specific criteria who we want in a study. It's everybody with a Fontan gets invited to be involved in the registry. What does the study do? It just observes these patients and participants passively over time. We don't intervene. We just kind of monitor and see what the natural history is of those patients with that disease and with that physiology. It's very different from what would be a clinical trial. The different things, which it's a very rigid study where the doctors and patients involved have a very specific protocol that they follow, and everything is very tightly controlled. We're not comparing specifically two different treatments or two different groups. And as a result, because there's so much variation in the people participating in the study, it's not free from things that we call confounders, which is characteristics of all the different patients in the study that can sometimes interfere with our results without us knowing about it, or bias, which is basically little flaws in the design of any study that can sometimes interfere with the results. But what do we get from these population-based studies? And this is why they're really useful, is that we get real-world outcome data. We get information about what really happens in the world, outside of the results you get from a highly controlled, very tight clinical trial, okay? Because that's not necessarily how most people experience things. We get pretty good papers and pretty useful information out of it all. Despite the Fontan Registry data being very good, any population-based study, the results do need to be interpreted with a little bit of care. As I mentioned, if there's a big variety in the patients that come in, there can be confounding factors. There can be some biases involved in how the study is set up and interpreted. If all the patients out there haven't been followed up, we don't have up-to-date information on everybody, there can be some problems with follow-up and how complete that is. And as time goes on and practice changes, it's a little bit different. So when we look at results out to 20 years after a Fontan, those people who had their Fontan 20 years ago would have had a very different operation and very different care to those who are having their operation these days. So the results saying the 20-year results now may not be applicable to people having Fontans in this day and age. There's other little tricks we can do to help minimize the bias and confounding that we come across. So, for example, if there's a population of patients that have two different treatments, something like the extracardiac conduit or the lateral tunnel Fontan, subconsciously doctors and surgeons might have inadvertently selected some of the smaller kids to go for a lateral tunnel Fontan or the bigger kids to have an extracardiac Fontan. So if we compared those two procedures, we may not necessarily be comparing equal groups, okay? So comparing that treatment, those two treatments, isn't really very fair because the two sets of patients going into it are quite different. What we can do is take the big population and try to take out a pair from one from each group, so we end up with two smaller groups that are very equally matched having each operation. And so we just compare those two smaller groups and have a much more realistic and much more accurate assessment of the treatment. And we call this propensity matching. How are the results presented? And this is really what you're most interested in when you end up looking at these papers. What are you going to see? And you're going to see stuff like this, which is a big table full of numbers, acronyms, long words that don't necessarily need to be that long sometimes. And this is a pretty small table. Sometimes they're much, much bigger than this. And it's pretty difficult to get your head around initially. But essentially, it can be quite straightforward. So you're looking at an outcome or a result, such as prolonged effusions after the Fontan procedure. And we're looking for things that can predict those outcomes. And in this situation, they've picked out 4 things here. So morphology, concomitant or additional procedures, arteriovenous malformations, and the age at which the child underwent the Glenn procedure. And it's using different statistical models to see which characteristics predict these outcomes. And they tend to use 2 different statistical models. I'll explain what that is. So the univariable model just picks each characteristic independently and on its own. So for example, whether a child needed an additional procedure at the time of its Fontan. They took all the kids who had just a straightforward Fontan and those that had an additional procedure at the time, and they tried to calculate which ones were more likely to have pleural effusions, who had in which group. It doesn't really assess the impact of any other characteristics on this result. It just looks at these 2 groups in isolation of everything else. A multivariable analysis looks for associations between all these characteristics, and so tries to find out truly which characteristics are really linked with that outcome afterwards, and tends to be more accurate than a univariable analysis. And so when you go back to the table, even though you've got 4 listed here being associated with the effusions, and we take the more accurate result, 2 of these drop away, and we're really only left with 2 characteristics here which are associated with the pleural effusions. But what do all these numbers mean, and what kind of sense are you going to make of all that? So they'll often come as, OR, which is odds ratio, or OR as relative risk, or risk ratio, HR as hazard ratio. And as far as you're concerned, they're all pretty much the same thing. It's comparing the risk in one group to the risk in another group. So if there's a 20% risk in one group, a 20% risk in the other group, they're divided by each other, you get an odds ratio of 1, which means there's no difference between the 2. If the odds ratio is less than 1, that group is at lower risk. If the odds ratio is bigger than 1, that group is higher risk. And when we go back to our example, those who had a concomitant procedure had an odds ratio of 2.1, which basically means that those patients have 2.1 times the chance of having prolonged pleural effusions after their Fontan. So once we've figured out what this means, why do we need to have all these other numbers on the side as well? And essentially that's us hedging our bets. So we take the result here, and so the odds ratio of having prolonged pleural effusions if you've had concomitant procedures is 2.1. But if we want to be as clear as possible and as accurate as possible, we say that we can't be 100% sure that the answer is 2.1. But we can be 95% sure that it is somewhere between 1 and 4.4. Okay? So that's medical literature, okay? Nothing is straightforward, and there's always that little bit of gray area. But that's what that means. Once you've had that, then there's the next set of numbers over to the side, which is the p-values, okay? And then to add more uncertainty into everything, this comes up and it really refers to the idea of statistical significance and essentially how likely we were to have come up with this answer by random chance. And the p-value, p just stands for probability, so the probability that we got this result by chance, and it's not really accurate. So a p of 0.25 means there's a 25% of 1 in 4 chance that we got this result by chance, which isn't very impressive. A p of 0.05 means a 5% chance that we got this answer by pure random chance, which is kind of the cutoff we've established in the medical literature for an acceptable level of error, for want of a better word. But it can be much lower, so it's down to a 0.1% probability of error or chance. When we go back to our example again, we can see that both of these have pretty small p-values, so 0.03% and a 4% chance that these 2 variables here are not actually associated with pleural effusions. So we can say we can be very confident that those results are true and those results are accurate. And that's what the p-value stands for. So, straightforward, eh? When we put it all together, you get a chart like this. It's looking at a post-Fontan outcome, and we take some pre-Fontan characteristics of the patients. We can use a reasonably accurate or a more accurate measure to determine which ones are truly linked with that post-Fontan outcome. We can see how strong the association is. So those with an additional procedure are twice as likely to have prolonged effusions. We can say that if we're hedging our bets a little bit, it's somewhere in that range there. And we're pretty unlikely to be wrong about that answer. To make it a little bit more interesting, sometimes we put it all together in a bit of a picture or a curve. Okay? These are slightly easier to understand. We call them Kaplan-Meier or event curves. And they're all laid out according to a fairly standard format. We put time down on the bottom here, years since the Fontan procedure. And on this side here, it's nearly always a percentage. And the way it's done is somewhat backwards to how you'd expect it to be. Okay? When you're looking for an adverse event, usually expect that, oh, there's a 10% chance or a 20% chance after a little while. The way it's usually done is calculated backwards, say the chance of freedom from that adverse event. So in this situation, it's freedom from late reintervention, which basically means the chances of needing another operation after your Fontan procedure. So the minute the Fontan procedure is finished, nobody's needed another operation straight away. So we all start off at 100% freedom from needing another operation. And then all the people are then followed over time for years and years. Every time somebody has needed an additional operation, this line drops down a bit. So then we can say that after 5 years, we follow that line up to here and across, we can be pretty sure that it's about 95% are free from needing another operation. So there's a 5 to 10% rate of needing another operation in that time period. You can go out to 10 years and follow it up and come across and say it's probably in the mid-80s. So 85% freedom from needing another operation. I mean, about 15% of children needed another operation within 10 years. And that's what that black line is. So again, the gray area we discussed earlier on, again, that's us with the 95% confidence interval hedging our bets a little bit on this. Okay? So the black line is our best guess on it. But as you can see, as we go further out in time, we have less and less patients to follow who are really out 14 years after a Fontan. So our estimates are slightly less accurate. So the gray area is a bit bigger. But we can be pretty accurate in this region here. Still fairly accurate out at 14 years. Sometimes you get two curves. And this is really when you take two different groups and compare them. Okay? So it all starts off the same. Time along this axis here and the percentage along here. So freedom from adverse events. So everybody starts off at 100%. And then we follow the two groups and we see this group A seems to be doing better than group B. So you can go to 5 years and say that group B, about 25% of them had an event, compared to group A, probably only about 10%. These curves, when it comes like this, will nearly always come with a p-value as well, okay? To say that there's a difference in our picture, and how confident can we be that that's true and accurate? And we see that in this picture, it's only about a 0.1% chance that the results are inaccurate. So we can be pretty confident about that. So understanding the results is not just about understanding the curves and the numbers. It's about understanding the limitations of some of these results as well. And it's stuff that I've already touched on a few minutes ago. There's a lot of variation in any registry population. As you know, patients have been recruited into the Fontan registry with different types of Fontans. They've had different types of underlying cardiac anatomy and diseases. They've got other types of medical problems. So necessarily the result from one of these curves is from the whole population and may not be completely applicable to any one individual patient. The follow-up is very important, and if you don't have good, accurate follow-up information, that's why you get those big, wide gray areas later on down the line. And importantly, as time goes on, practice changes, and the information we have on 20-year results is on those people who had their operations 20 years ago, and the standard of care and the type of operations they're receiving now would be significantly different. So those results shouldn't be the same in 20 years' time. Thank you very much. Almost afraid to ask for questions. Stunned silence. I know, very good.
Ben, I've got a child that's almost 2, so he's on a pathway to content.
Yeah.
And I don't know how many in the room are in the situation that I'm in, or how many have got a child with content. I just wonder, with the registry, whether you've ever looked at expanding to include those of us that are trying to anticipate what might happen before we get to where you guys are. And whether I understand there's probably a lot of valuable information in the room from parents that are ahead of me that I want to get.
Yeah.
I'm happy to take that question, Ben, if you'd like. Certainly the Prefontaine pathway is very, very important in defining what will happen at Fontaine and thereafter. And as we dig deeper into the data we have, we're picking out individual patient groups that have a certain form of pattern and analysing them separately. So yes, we are doing that, and we should have that sort of information to present in the next few years.
Yep. This is certainly the only Fontaine registry anywhere in the world, as far as I know. Specifically about this.
There are a few other registries around, but the key features about this registry is that it's truly population-based, and so that tells us what the outcomes are going to be like for the whole population, rather than just the type of patients that are referred to a specific centre. There are some smaller registries in the US, but they're usually from centres that have a very high proportion of very complex patients. And so their outcomes tend to be worse than what we are reporting. Eve, did you want to comment any further? Okay, we might just take one more question. We just need to move on. All right, thank you very much, Ben. That was a terrific presentation.